Good afternoon. On behalf of the Lupus Foundation of Minnesota, I want to thank everyone for joining us today for this webinar, Neonatal Lupus, Facts and Fiction. My name is Sandy Parnell, and I'm the Director of Education and Supportive Services at the Lupus Foundation of Minnesota, and I'm very pleased to introduce our presenter, Dr. Jill Buyon. Dr. Buyon is the Director for the Division of Rheumatology at the New York University School of Medicine, the Lupus Center at the NYU Langone Medical Center, and the Research Registry for Neonatal Lupus. Before Dr. Buyon begins, I want to talk a little bit about how the webinar system works. At this time, make sure your webcam function is off and turn on the mute function. Only voices you will hear are Dr. Buyon's and my own. And your audio should be heard through your tablet or your computer. We invite questions during the presentations. Please type in your question in the sidebar, and we will have Dr. Buyon respond to them at the end of her presentation. Also, we're recording this session for future audiences, and it will be archived on the LFM website. At the conclusion of the webinar, you'll receive a brief survey. Please take the time to fill it out because your feedback helps us shape our future programming. And finally, if you'd like a certificate of attendance, please just email me at sparnell@lupusmn.org. Welcome, Dr. Buyon. We look forward to your presentation.
All right. Thank you, Sandy.
Yes.
So today's discussion will be about neonatal lupus, facts and fiction. I think it's not moving. Hold on a minute. Slight technical glitch. Sandy, the slides are not in. Okay.
Did you do that? Yeah, okay.
I think I just did.
Good, okay.
I hope it's not too much of a delay. It gives you a lot of thinking between slides. So why are we having this webinar today, and why do you need to know about neonatal lupus? And I'd like to present 3 scenarios which I hope, following this webinar, you'll have a better understanding of. The first, a 26-year-old pregnant Caucasian female who has always been healthy presents for routine ultrasound at 18 weeks during her first pregnancy. Her obstetrician finds an abnormally slow heart rate and refers her to a pediatric cardiologist who tells her the baby has permanent heart block in the heart and may die or need a pacemaker for life. The young woman is told that she has an autoimmune disease, and this has caused the baby's heart condition. Faced with potential disease in herself and a life-threatening disease in her baby, she's also unsure who to turn to, since her physicians tell her these conditions are quite rare. A 33-year-old black female has had a previous child with heart block that died at age 3, awaiting transplant, and is told that this problem will happen again. She is afraid to face another pregnancy. A 22-year-old Hispanic female has had a previous child with a periorbital rash and scalp rash, which was initially considered fungal. Eventually, she was tested and found to have anti-Rolla antibodies. She was told not to worry about problems in her current pregnancy. So as we go through this webinar, I hope you'll see that each of these vignettes is quite illustrative, and we have approaches to all 3 situations. Sandy, do you think maybe you should try to advance?
Okay. I guess I'm the holder of that clicker.
So I'm relinquishing control early on. Very good. So what are we talking about today is neonatal lupus, which is considered a model of passively acquired autoimmunity where a mother can have lupus, she may have Sjogren's syndrome or both, or in fact she may be totally asymptomatic. We'll get back to that. The commonality is that these women make one or all of 3 autoantibodies to SSA-Rho 52, 60, and SSB-La. These are autoantibodies reactive against self, and these antibodies, just like normal antibodies, cross the human placenta at about 11 weeks by a receptor called FcR2b, and these antibodies are then transported into the fetal circulation, and in rare cases, these antibodies can cause congenital heart block or the neonatal rash. Sandy? So up front, let's correct some confusion. First, the name neonatal lupus causes confusion because in some cases, or neither the mother, and that's in most cases, nor the baby actually have systemic lupus erythematosus. So just because a mother is found to have anti-Rolla antibodies does not mean that she has lupus. The finding of a slow heartbeat in a fetus, even in a totally healthy mother, should prompt testing for anti-Rolla antibodies. And antibodies to Rho are the same as antibodies to SSA. Next. So this is a rare disease, and we'll discuss that in a moment. But to study a rare disease, we at NYU, in cooperation with the NIH, have established a research registry for neonatal lupus, which has been in existence since 1994, and it's currently the largest database in existence. And our purpose was to provide a source of well-documented cases, inclusive of mothers and their children, available to researchers interested in basic science or clinical studies. Currently, we have enrolled 503 families, of which 627 have some manifestation of neonatal lupus. Next. So what are some clinical facts about the skin rash? We'll start with the skin rash, and we'll move on then to the more serious manifestation being heart problems. So with regard to the skin rash, the risk is about 7 to 16% if a mother has never had an affected child. The rash is detected at birth up until 6 weeks and can be provoked by UV light, so mothers are advised to be very cautious about taking their anti-Rolla exposed babies into the sunlight. The rash represents adult subacute cutaneous lupus, and it really was based on this rash that the name, which we've already discussed was a misnomer, came about to be neonatal lupus. This rash, and I'm going to contrast this to the heart block later, is transient, with a mean duration can be up to 17 weeks or so, very rare scarring. And as I said, keeping babies sun protected. So except for ugly baby pictures, this is really not a major consequence. And I'll show you some pictures. Next slide. But before we get there, this is the distribution of the rash, and this was based on a study of 57 children. The important fact, in every case that we are aware of, the skin rash affects the face. But as you can see, it can be around the eyes, the scalp, can be on the trunk, extremities, neck, in between skin folds, and even on the palms or soles, but that is quite rare. Characteristic is on the face and in a periorbital distribution, as I'll show you. Next slide. So here is an example of a skin rash. This is really a fairly mild case, to be honest with you, and you can see the kind of owl eyes of the baby. And if you look closely, you'll notice that the circles are kind of like targets. That is, there is a redness around them in a circle. We call these sort of circular lesions. And so that's characteristic that there's pale in the inside and there's the redness on the outside, like rings. I think that would be the best way to describe it. Next slide. And so now you see the resolution of this rash as the maternal antibodies are cleared from the baby's circulation. Next slide. But in some cases, this can be far more severe, as in this young boy. In general, even this clears up, perhaps in this case, with some slight scarring. But also notice the face and near the ear. And importantly for the mothers, this rash is often, at least the more mild forms I showed you, and the face on this baby can look fungal. And that's often a common mistake, is that this is attributed to a fungus and the mother is never tested for antibodies. If she comes in with her baby and she's known to have lupus, that becomes more obvious for the pediatrician. So sometimes it can be a tricky situation. Next slide. Now, people often ask me about breast milk and breastfeeding. And this complicated slide, which we call a Western blot, basically shows you where you see those little black lines, and I'm sorry, I don't have a pointer, that is showing the antibody in both the serum, that is the blood product, or the milk, that is the breast milk, contain antibodies to these Rho and La proteins. And so some people have asked us, gee, what do we do about breastfeeding? Does this really add to the risk, and particularly to the risk of a skin rash, because that's something that happens at birth or after birth, in contrast to the heart, which I'll tell you. And the bottom line to keep of note is that breastfeeding has no untoward effect that we know of on the development of rash. So there's no reason to stop breastfeeding if you happen to have anti-Rho antibodies. Next slide. So what happens to the children when they grow up? Well, this is actually an important study that's ongoing presently. But when we looked in 2002, we asked the question, and these are all exposed children to Rho antibodies, and the mothers could have been asymptomatic, have lupus, or have Sjogren's, but they're all anti-Rho exposed. You see in yellow are affected children, meaning rash or heart block, and in pink, these are siblings, also exposed to Rho antibodies, that are totally healthy. And what you can see, and it's interesting that it's coming not just from the affected, but in some cases, if you go to 21 to 24 years, there could be some little blips even in the unaffected. But it's rare to develop autoimmunity so far in these children. There have been juvenile rheumatoid arthritis, little thyroid disease, and the development in very rare cases of ANA positivity. So at this point, and you'll notice there's no lupus on here, number one, we're accumulating far more data, and it's a very important study, I think, to reassure the mothers about where the health of their own children with regard to autoimmunity will land. So this is still a work in progress, but I think a very important point that we'll have more information, hopefully, in the next few years. Next slide. So I want to turn now to the far more serious manifestation of neonatal lupus. And here are some clinical facts about congenital heart block. And just to clarify again, congenital heart block is a slowing of the heart, where the top of the heart actually is traveling to the middle of the heart, and there's a block in the middle. And that results in a slower heart rate from the fetus. So usually the top of the heart, or what we call the sinus node, or the atrial rate, is actually normal, where it's the ventricular rate that's slow. And I've received that question occasionally from some of the mothers. What's the bad news? Well, about 20% of these babies, unfortunately, die before 1 year of age. Most, if not all, require lifelong pacemakers. But there's good news. The vulnerable period we know, or at least current work suggests, is between 18 to 24 weeks of gestation. Some people put that window at 26. So that has implications for fetal monitoring that we'll talk about. And as I'll show you in a moment, 80% that live can live a very healthy life and even work in our research laboratory. We've had several of the children working in our lab, and they function normally. Some of them have been athletes, college, etc., doctors, lawyers, all that, and having their own healthy children. Thank you. Next slide. So what are the risks of developing congenital heart block? Well, let's look at it one way. If there is a mother who is otherwise healthy and heart block is identified in her fetus, you can evaluate that mother's blood, and 85% of the time, that mother, knowingly or unknowingly to her, will have anti-Rho antibodies. But taking it the other way around, hold on, there's a little thing in front of me now. 1 second. Sorry. Okay. Taking it the other way around, if a mother has Rho antibodies, this does not mean she will definitely have a child with heart block. In fact, if it's a first pregnancy or she's never had an affected child, that risk is 2%. And if the mother has Rho and or La antibodies and a prior child with heart block, this risk goes up about tenfold. What that suggests is that the risk factors for the development of heart block require the Rho or Rho and La antibodies, but they're not sufficient. So there must be some factors in individual fetuses that confer risk. And what those factors are, for example, genetics or other in utero clues, proteins, are areas of intense investigation. Importantly, and not totally understood, the mother's heart, which is exposed to the same antibodies as the fetal heart is not affected. So there's something about the fetus that makes the heart vulnerable. Another very important point with regard to counseling is that the fetus can be in normal sinus rhythm and within 1 week develop complete and irreversible block, which tells us that we have a short window to intervene if we're going to, and that some kind of tissue damage program, when exposed to these Rho antibodies in certain fetuses, is very, very rapid. Next slide. So there are some research challenges. Number one, we've already discussed that antibody alone is insufficient. Of course, the disease being rare, which is why we put together a registry. There seems to be a contribution to fetal factors, and because it's so rare, there's probably a very complex pathogenesis. And for us as scientists, these Rho and La proteins called antigens are located inside the cell. And if they're located inside the cell, how does the antibody actually get to them? So there are two hypotheses for why the problem happens. Perhaps there are others, but these are two prevailing hypotheses, is that the mother's antibody is recognizing Rho or La in some cases, but that's not really the target. And that target is something else on the fetal heart that's not on the mother's heart, and that target might represent a calcium channel. Another theory is that when a cell undergoes what we call programmed cell death, which happens as a fetal heart is developing in other tissues, the cell undergoes remodeling. It's like remodeling a sculpture. If you have a piece of clay, you have to cut off little pieces that you sacrifice to make the whole. And during fetal development, particularly in the heart, there's something called apoptosis, where cells are dying. Next slide. So this is showing you an autopsy from a fetus that unfortunately did succumb to heart block. And what you can see, panel A and B are higher magnifications. We're going up with A, B, C, and D. And basically just focusing on A, the arrow where it says AV node is pointing to an area that should not be blue. That's the area of the middle of the heart where the top comes and sets a beat there. That piece is no longer there. So the middle connector, like monkey in the middle kind of thing, is gone. And so the pacing that came from the top can't get through to the ventricle, and the fetus is then reliant upon the ventricular rate as the heart rate. And the reason this happens, as you can see more in panel C and D, is that this area has now become fibrose and calcified. And what you see in D is that there are inflammatory cells. You see where I put the arrow to giant cells that are infiltrating into the heart. So the clues here are the problem relates to too much scarring and inflammation. Next slide. So for some of you who might be interested in the science, what the heck, you might ask yourselves, are Rho and La proteins? And this is just a schematic showing us that these Rho, that the 60 Rho and the 48 La, importantly in the blue, have areas that bind what we call RNA. And this makes for what we call a ribonuclear protein. And although the antibodies bind the protein part, Rho and La do bind these small RNAs. 52 Rho is actually quite different. It's called TRIM2. It's known to be an E3 ubiquitin ligase, and that is another target, but that is not really a Rho binding protein. Next slide. So this is a very simplistic view of our current thinking about how anti-Rho antibodies cause inflammation and fibrosis. And so if you start out on the left, this is supposed to represent a heart cell. And during normal development, in probably all fetuses, Rho, which is inside the normal cardiocyte, moves to the surface. So what? Does it really have any consequence? When it moves to the surface, it brings a little piece of RNA with it. Now, again, so what, you might say? That's fine. But what happens when a mother happens to make anti-Rho antibodies that come across the placenta? All of a sudden, the antibody is now seeing Rho. That Rho antibody wasn't supposed to be there. By being there, it binds to the Rho on this dying cell, and this creates what we call an immune complex. Some of you who have lupus understand something about immune complexes because this may be a similar process that happens in lupus affecting the kidney disease. Anyway, this complex needs to be taken away. That's not a good thing to have this complex. And so let's call in some soldiers to help us eat this up. Well, normally when some of the cells go around eating up the dead cells to make the sculpture, that's fine. They do that without any inflammation. But those dying cells were not decorated by an antibody. So this little scavenger cell, which I've called in yellow the macrophage, sees that immune complex and thinks, oh, I got to eat it just like I would eat any dying cell. But this immune complex is sugar-coated. And that coating, based on the antibody binding, is taken up by the macrophage that gets very angry at having done that. And by taking up this kind of over meal that's decorated, instead of cleaning up the mess, throws up instead. And in a sense, that secretion of, we could say vomitaceous material or what we call cytokines can take the fibroblasts that are around the heart and actually cause them to be scarred. So this is one possible way that we are linking the antibody to the end stage situation, which is scarring of the AV node. Next slide. Oh, are you going to do the next one? I think we're stuck looking at this. This is the one that had that. Yeah. All right. Sorry. Okay, go to the next one. Okay. Now, for those of you who may know a little bit about getting your blood tested, this has been controversial. Are there any particular row and long antibodies that are more likely to confer risk? So these are just some facts that we as physicians think about in counseling women. Number one, reactivity to native row 60 is the most sensitive test for the development. Now, I said cardiac neonatal lupus. I could put congenital heart block there. And in this case, most of the ways that we test for row antibodies in our clinical practice does involve evaluation of native row 60. So that's good. Over the years, there's been some discussion that a particular piece of the row 52 may add risk over measuring row 52. This is not done in a commercial laboratory, and our work has really not shown that antibodies to this particular segment confers much risk over just measuring the whole row 52, which is done in a commercial test. Now, for a mother who has a child with cardiac NL or neonatal lupus cardiac disease, the frequency and the titer of either the row 52 or this little experimental piece don't really inform you whether there's further risk for recurrence. Now, although antibodies to row 60, row 52, and this piece of 52 are none of them very specific for getting the disease, meaning you can have it, but having the disease, of course, is more rare. It has been shown that reactivity to the little piece is at least likely to be false positive in mothers who've never had an affected child. But is that worth going out and getting this antibody as a research tool? We don't feel at this point it really adds much information. And it's important to know that when you get your lab tests back, if your amount or titer of anti-row 60 or any of these is very low, it may require less stringent echocardiographic monitoring. Why? Because that's less associated with the development of heart block. Next. So this is just a little tip about vitamin D. There was some discussion that vitamin D might matter in this case because vitamin D actually has some anti-scarring effects. Many of you may not have realized that. So we went ahead and we looked at vitamin D levels in a mother during pregnancy where she has row, and in one pregnancy she had a child with heart block, 50 of those, and in another pregnancy she had a child that was healthy. And you can see actually there were no differences between whether the child got heart block or didn't. But if we looked at timing of pacemaking later on, then it turns out, and I've written this in the bottom, that higher average levels of vitamin D during pregnancy, although they didn't segregate heart block from non-heart block, whether we looked anytime during pregnancy or right at the vulnerable period, as in panel B, that if you looked forward, that is, after the baby was born, if you had higher levels of vitamin D during pregnancy, it seemed that pacing occurred later. And obviously, the later or the greater time period you can delay pacing, the better off it is for the ultimate prognosis of the child. So we recommend that mothers do have their vitamin D levels checked during pregnancy, and if they're very low, we do suggest that they are repleted with vitamin D in discussion with their obstetricians. Next slide. So what's the outcome of children who have cardiac NL or heart block? Well, we've already mentioned that the overall fatality is about 20%. In this particular very large study, it was 17.5%. The probability of dying in utero was 6% in this study. But the good news is that you make it to birth, the cumulative probability of survival at 10 years for a child born alive was 86%. So far, we've had 70% receive pacemakers and 4 received a transplant. Next slide. So what are the risk factors that associate with this mortality? So this has been evaluated both in the United States, the top by Ismaili, and in Europe. And the factors that can be identified in utero that are associated with mortality include something called endocardial fibroelastosis. This can be seen on echocardiogram as bright spots, hydrops, earlier gestational age at detection, and low ventricular rate. So translated, if the heart block happens earlier than 20 weeks, that is more dangerous regard to fatality than if the heart block occurs afterwards. And if the heart rate is less than 55, this is, or actually as you'll see in the bottom, less than 50, this is more likely to be associated with death than if the heart rate is greater than 50. If the heart doesn't function quite well, meaning that the left ventricular function shows that the heart doesn't pump well, that's a poor prognostic sign, again, less than 20 weeks, and if the baby is very fluid overloaded. Now, it's interesting, and this is an important fact for mothers facing this and thoughts about continuing a pregnancy or not. If all that is found is isolated heart block, and that's third-degree block, because second degree may be better, then the rate of death is about 7.5%. But if there are more things than just a block, that is, the heart's baggy, it doesn't function right, or there's endocardial fibroelastosis, this fatality rate goes up to 30%. So again, in counseling, being faced with the problem, some of this knowledge is very important in decision making. Next slide. So what about if the fetus is identified to have what we call an incomplete block? And that is, instead of having that node in the middle totally scarred, what if it's only a little scarred? Meaning some of the beats get through from the top to the bottom, but not all. In this case, what we're showing in this slide is the encouragement, although it's not statistically significant, there's an encouragement that fluorinated steroids, meaning dexamethasone, may have an effect on reversing second-degree block. And so that's one of the important reasons to have fetal monitoring is this might be the one setting in which intervention could make a huge difference. But again, the numbers are very, very small, and it's not a universal recommendation because there can be some side effects of steroids. But many of you may hear about this, so these are the data that support the use of fluorinated steroids to try to reverse second-degree block. Next slide. So many patients and physicians think about, well, okay, heart block has happened. Is there anything I can do to reverse the problem? And so thinking about that, one thing that comes to mind are using steroids and fluorinated steroids, meaning specifically dexamethasone or betamethasone. The reason these steroids are used is because they cross the human placenta. If you take prednisone, and many lupus patients, of course, do take prednisone, most of the prednisone is inactivated by the placenta. And that's why that may not be effective in treating the fetus. It may treat the mother, but not the fetus. But at any rate, we've addressed, I'll show you another slide, and so have other studies, should all mothers whose children or babies are identified to have heart block in utero, should they all be given steroids, regardless of whether it's third degree, second degree, or worse? And the answer that we've come up with is probably not. But the Canadians felt that by using steroids, even in third-degree block, that this might have a good prognosis ultimately. However, this was contrasted by a study in Europe that said, no, we really don't think there's a reason to initiate steroids if all there is third-degree block. So we tackled that problem. I believe that's the next slide. And here you can see is fluorinated steroids do not seem to influence the outcome of isolated heart block. And without running through the numbers in the interest of time, taking steroids, if all you had was third-degree block, did not influence the development of cardiomyopathy, did not influence survival, and did not influence the implantation of a pacemaker. Next slide. So let's just talk about the management of a pregnancy where the mother has Rowan-Law. So get pregnant. I would say it's important to have detailed counseling by your rheumatologist, but of course some of these mothers have no disease or minimal disease, and in conjunction with a fetal and pediatric cardiologist. We currently recommend fetal echocardiograms starting at 16 to 18 weeks and going through 26. We used to recommend that we had biweekly echoes continue from 26 to 34, but as we have done more prospective studies, we've noted almost never do we see signs of injury after 26 weeks, suggesting again that there really is a fetal vulnerable period. But of course, everyone knows in lupus and other diseases, the rules are meant to be broken. If all the fetal echoes are normal, we would suggest a postnatal EKG for sure, echocardiogram if financially feasible, etc. And we would do that at the first month of life. Some people do it at birth, but the first month of life would be fine, and maybe to be obsessive, 1 year of age. But if everything's been normal in utero, probably at that month point, this could be the last one, the last time a mother really has to worry about this. Now, what if there's something called an abnormal PR interval, and that's just a way of trying to find something called first-degree heart block, and which is why we have the mothers go for echocardiograms, because an echocardiogram can pick up what we call first-degree block that cannot be picked up by just listening or looking at just listening to the heart. So echocardiograms can pick up first-degree block. If first-degree block is picked up, and we usually define that as 150 milliseconds, not 140, we may suggest a short trial of the anti-inflammatory we were just talking about, dexamethasone. And if we see second alternating with third or just second, again we might consider dexamethasone. If we see signs of more than just heart block, as we mentioned, again we might consider dexamethasone. But important as in white, if all there is third-degree heart block, then we don't recommend any therapy except continually watching the baby by echocardiogram. And if there's third-degree block and the fetus is very hydropic, we've already said that carries a very poor prognosis. Although people have considered Dex, IVIG, literally removing the blood from the mother and trying to cleanse it of the antibody called apheresis, and in some cases, unfortunately, discussion of termination. Next slide. So the optimal approach is kind of logical, would be to prevent, and prevent primary and secondary. And it's very clear that having one child with neonatal lupus increases the risk of recurrence in a subsequent child. And basically, just to kind of look at numbers, having one child with heart block, the risk of having a second, somewhere around 17, 18, 19, 20%. But importantly, if you've had a child with rash, you're also increased risk for heart block. It goes beyond the 2% if you've never had an affected child, and those numbers are somewhere between 13 and 18%. Next slide. So why embark upon a prophylactic therapy? That seems obvious. There's a clear need. We have a significant morbidity and mortality, and fibrosis is immutable. Our opportunity is that the risk is identifiable. We have a database available to predict outcomes, and we should be able to translate research clues. Next slide. So just to kind of put a damper on this, taking prednisone, so far the data do not support that doing that will reduce the recurrence rate. Next slide. Also, taking dexamethasone beforehand, and the numbers are small, does not seem to reduce the recurrence rate either. Wait, I think you went backwards. So neither prednisone, the one that doesn't across the placenta, nor dexamethasone, the one that does. It doesn't seem like doing that ahead of time reduces the recurrence rate at this point, although there are certainly patients who've had more than one child and the doctors feel ultimately compelled to do something. This is often considered. But also keep in mind that unlike other autoantibodies in lupus patients, anti-Ro and antibodies are not lowered simply by taking steroids. Next slide. So there has been a biologic rationale for the use of IVIG in the prevention of heart block, and there's several reasons for this. One, that it might decrease or eliminate maternal antibodies in the fetal circulation by binding to that special receptor called FcRn, and IVIG may contain anti-idiotypes that might promote responses in the mothers and, in a sense, block the antibodies. And from the fetal perspective, this particular treatment, IVIG, can attenuate anti-inflammatory responses of the fetal macrophage by increasing the expression of an inhibitory receptor called Fc gamma R2b. And I'll just illustrate that in the next slide. This just is a diagram, a little more complicated than the one I just showed you. Concentrate on the bottom. So if you gave IVIG, you might block the placental transport of the antibody, and you might also make that angry macrophage less inflammatory and likely to throw up and change the fibroblasts to a scar phenotype. Next slide. Oh, next slide. So what were the results of a prospective trial that we did? Now, importantly, this trial was done both in the United States and England, and really the dose that we were to give of the IVIG was unknown. So we went with a dose that is used to replace immune globulin. It was a dose that was not quite the anti-inflammatory dose, and our reason for going lower was that we didn't know exactly what concentration we would get in the fetus, and we thought that the fetal effect would be mostly on the macrophage. We were not convinced that we'd really lower the antibodies, either being crossed or through the mother circulation. So we decided, for right or for wrong reasons, to go with a low dose of IVIG. And the dose we used was 400 milligrams per kilogram every 3 weeks between 12 and I think it was like 25 weeks. The bottom line is it didn't work. At least at those low doses, 2 prospective studies bang on showed that the recurrence rate was 18%, unaltered by the use of IVIG. Next slide. But there's still thoughts out there about using higher doses, I might say, of IVIG. Keep in mind, very expensive approach. So we then thought about the inflammatory cell, and we said, gee, how could we inhibit inflammation? Well, there's a drug out there used by, in fact, many lupus patients during pregnancy called hydroxychloroquine. What this does is this inhibits the macrophage secretion of all of those bad cytokines that change the fibroblast. So when the macrophage takes up that immune complex we were talking about earlier, this drug, hydroxychloroquine, blocks the inflammatory response by the macrophage. Next slide. So what about using hydroxychloroquine? Is it safe? There have been over 1,000 pregnancies of women with lupus that have taken this drug without any untoward effects. And although it is labeled Category C, and some of you may know that those categories are changed now, and instead of categories, it's basically facts. And here are the facts. No congenital malformations have been reported in over 250 children studied. It's probably closer to 1,000 now. No hearing or visual abnormalities were identified in a study of 58 exposed children. And it's also of interest that for lupus mothers, hydroxychloroquine may prevent flares during pregnancy. So there are several, or rather there are many studies supporting the safety of this drug, but I always do discuss with the mothers that this drug crosses the placenta, and in fact, that's the whole point. We do want it to cross the placenta to try to stop the inflammation in the fetus. Next slide. So this just runs through some information that's already published. It's particularly useful for the doctors who want to prescribe hydroxychloroquine. And basically, when we studied mothers with lupus and we asked about taking Plaquenil or not, and those were all Ro positive mothers, did it have any effect? And the answer was yes, it seemed to reduce the risk of heart block in Rho-positive mothers who had lupus. This was very restricted to lupus mothers in this study, and it took all comers, first or second pregnancies. So it was suggestive, but again, it's a retrospective evaluation confined to mothers with lupus, but encouraging. The next study we did, on the next slide, we asked, okay, if we combined registries from US, France, and the UK, what happened in a next pregnancy if the mother had a baby with heart block and she took Plaquenil or not? And again, this was not a prospective study. It was going through databases. Then what happened to the second child relative to the use or not use of hydroxychloroquine? And as you can see, if you were on hydroxychloroquine, that is, there were 40 such subsequent pregnancies, 3 or 8% were affected. If you were not on hydroxychloroquine, so 217 pregnancies after the birth of a child with heart block, 21%. So this suggests, again, supports the idea that there might be a benefit of hydroxychloroquine in reducing the recurrence rate. But note, it is not absolute. As you can clearly see here, 3 of 40 cases did develop heart block despite the use, but this is a half the rate that we might otherwise expect it. Next slide. So based on this, and actually this is work promoted by several foundations at NIH, and I will get to those acknowledgments at the end, we embarked upon a preventative approach to congenital heart block with hydroxychloroquine, or the PATCH study. And the study basically enrolls women, and is ongoing right now, so it's important if there are any women out there who might be interested or doctors who have patients, refer them to us, that a mother is started who has to have a child with heart block, and the mother has to be before 10 weeks of gestation. She is prescribed by her own doctor 400 milligrams of hydroxychloroquine daily, and she's agreed to send us her medical records and bloods every trimester of pregnancy. And the bottom line is that we're hoping to see less than 6 out of 54 enrolled mothers get heart block. And if we see less than 6, meaning 5 out of 54, we would consider the drug beneficial and probably begin to prescribe it in many women who've had a prior child with heart block. If you're interested in the study, you can see on the slide our contact here at NYU is to Sean Middleton. Next slide. So let's put this all together, and how do we approach heart block? So what about a mother comes in with anti-Rolla antibodies? Doctor, what can you do for me to prevent heart block? Well, perhaps high-dose IVIG. We've already said that low dose doesn't work. This is a very expensive medication, requires you to be in the hospital for several hours, and again, not proven. Considering hydroxychloroquine, very inexpensive, taken by mouth. Replete your vitamin D, but I would not recommend steroids. Weekly fetal echocardiograms between 16 and 26 weeks. If first degree or second degree is identified, perhaps dexamethasone to decrease the inflammation. And the bottom is, what could we do about scarring? At this point, we just don't have an effective therapy. But there are ways to inhibit TGF-beta, a particular fibrosing cytokine. We're not quite there. Importantly, get an EKG at birth or within the first month. And if there's no cardiac problems, then pat a woman on the back, and I think we would feel pretty good about that situation. Next slide. So this is really a slide talking about prenatal screening of all women who are pregnant and some of the reasons for it, but you should know that at the present time, there is no universal screening for maternal anti-Rolla antibodies, and in part, well, if we can't do anything about it, why are we finding out? Obviously, this is a very interesting discussion, but the cost of getting Rolla antibodies tested is peanuts compared to some of the genetic tests that are being done. In fact, it's less than $50. Next slide. So let's kind of summarize about our current thinking. Pathogenesis, we've reviewed. Cardiac apoptosis or cell death, which can result in immune complex formation, macrophage infiltration, and fibroblast differentiation to scar. Could this be molecular memory? Calcium channel, another theory. We didn't really discuss genetics. I think that's something we could set for another webinar, but it doesn't look like the mother's genetics are strongly influencing this, at least by an area called the HLA. There are some biomarkers. Anti-Ro is the most sensitive, Anti-Ro 52 is the most specific, and we've looked for anti-calcium channel antibodies, and these are indeed very rare. Some of the other proteins I'm mentioning below that are ways that we're trying to look at to see about the ultimate prognosis. The outcomes, 2% risk if never having an affected child, 18% recurrence, 17.5% morbidity, worst prognosis, cardiomyopathy. Treatment, none of third degree only, DEX if less advanced or beyond, disease beyond the AV node, and hydroxychloroquine is under evaluation for prevention. Next slide. So the key take-home points. Neonatal lupus is an in vivo model of passively acquired autoimmune disease in which Ro and La antibodies are transmitted through the placenta from a mother to her fetus. The most important clinical feature is congenital heart block, which is usually complete and irreversible. Additional cardiac abnormalities may be endocardial fibroelastosis and valve fibrosis. There can be transient skin, and I didn't really mention liver and hematologic abnormalities. These have been reported. In general, these go away without any treatment. People have discussed learning disabilities. These are probably absent, but again, a little more work needs to be done. Next slide. Therapy is based on expert opinion. Fluorinated steroids are generally used if the block is incomplete or recent or associated with hydrops, myocarditis, or diffusions. IVIG and plasmapheresis are sometimes proposed if the block is incomplete or if myocarditis or endocardial fibrosis is present, but the efficacy unproven. Infants are often delivered preterm, so we shouldn't be scared about that. The mortality, as we've discussed, is about 15–23% in broader studies, and permanent pacing is required in the majority. Hydroxychloroquine might have a role in preventing heart block, mediated by interference with what we call toll-like receptors, and we've discussed the open label study going on. Next slide. So let's put it in perspective. As little Anna H. said, she came home from kindergarten and she told her mom, she said, "We had a talk today about the heart. And you know what? I told everyone in my class, I don't have a heart. I have a pacemaker." Well, we have a long way to go, and I think we owe Anna continued research, and I'd like to thank some of the organizations that have contributed. Next slide. So I'd like to thank really support from the NIAMS, NICHD, the Minnesota Lupus Foundation, and the Lupus Foundation of America have been very helpful in supporting it, and these are some of the individuals who contributed to the science and the clinical work I've shown today. Thank you.
Thank you so much, Jill. There are a few questions, and it looks like we have some time for you to respond to a couple of those questions.
Sure.
One question is, if somebody does not live with SLE, lives with discoid lupus,
Yes.
Is it recommended that that mother would be taking Plaquenil as well?
Okay, so first we start out with discoid lupus, having nothing to do with this discussion, is a very important reason to be considered taking Plaquenil. So having nothing to do with Ro, having nothing to do with heart block, as a rheumatologist now wearing that hat, individuals with discoid lupus can benefit by taking Plaquenil. A person with discoid lupus can have Ro antibodies. The association is usually greater with photosensitive rashes or these malar rashes, but the use of Plaquenil to prevent heart block is irrespective of the mother's disease. But if a mother happens to have discoid lupus and Ro antibodies, what a great reason, because there might be benefit both to the mother and to the baby.
Thank you. A baby who is born with neonatal lupus, would that baby also be born with other autoimmune disease?
So we actually tried to address that around slide 9 or 10. And so the answer is we have a huge study going on to evaluate that. So far, there are some little hints about the development of autoimmune disease in the children, which may or may not relate to whether that child had heart block or not. But so far, and again, this is work that I'm hoping we'll have completed in the next 2 years as we call every single mother in the register and the children, some of whom are now in their 20s and early 30s, that it looks like the development of lupus, for example, is actually quite rare. And you might expect lupus to occur in about 10% of female offspring of lupus mothers. But so far, we're not seeing anything like that. We are also trying to test for ANAs and anti-Rolla antibodies, and so far, we have not found very few that are positive. So from an optimistic point of view, I would say in general, these children don't seem to develop autoimmunity, but this is a very, very important question that I'm not yet quite prepared to be. Don't worry at all.
Okay, thank you. You mentioned in one slide there's a contribution of environmental factors. Could you discuss a few of those?
Well, I wish I could, because that's the Nobel Prize. In utero, there's less oxygen, and you can imagine that situation. Maybe the fact that there's a little less oxygen could contribute to the problem. Obviously, it would be awful if women smoked during pregnancy, but thankfully, women really aren't smoking during pregnancy. And there may be some, let's see, in utero factors may be produced by the fetus, so certain proteins that may be pro-inflammatory may also contribute. And there are things like C-reactive protein. There are various molecules that may contribute to fibrosis that could be contributory from the fetal perspective. And I think that really is the million-dollar question. And I would tell you one other little fact that makes this even more challenging. We have seen identical twins sharing the same placenta. So they're exposed to the same anti-Rolla, and they're not always concordant for disease. Now, is it because one is bigger, one's pushing the foot and make the other one more hypoxic? So I think this is where research needs to go to identify what, in addition to Rolla antibodies, is causing this problem in really the rare fetus.
Thank you. That concludes our questions, and I think that concludes today's webinar. Thank you so much, Dr. Buyon, for sharing your expertise and your sense of humor. Provided an incredible wealth of information about neonatal lupus, and as you suggest in your title, you differentiated between the facts and fiction of that type of lupus. So thank you. I also want to thank everyone for joining us today for this webinar. Please go to our website, www.lupusmn.org, for more information about our programs and events. Thank you.